Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center. I'm here with Danielle Matias, my associate here, the other prolotherapist who helps run the Hauser Neck Center in Caring Medical, Florida. Part one of the headache series, we talked about together that almost all headaches have as their origin a ligament injury in the neck, ligamentous cervical instability, which then can cause any type of headache. So we believe in our experience that that's the number one cause of headaches now because of the face down forward head lifestyle with cell phones and computers. The second most common cause of headaches are tension headaches, and that was part two, where we talked about there's two kinds of tension headaches. One occurs acutely. For instance, somebody's gardening, they're just gardening, and then they have a lot of tension in their neck, then they get a tension headache. But most muscle tension headaches are actually chronic, like it always is tense up here, or always tense down there, and that probably has as its origin a ligamentous or joint instability problem of the neck. The muscles are tensing to stabilize the neck. And most people don't even realize how ligamentous cervical instability can cause migraine headaches. So the third most common cause of headaches or diagnoses that we see would be migraine headaches. And then why don't you talk about what is a migraine headache?
Yeah, the most people that come to our office, they have kind of chronic migraines, like what you had said with tension headaches, where there are some people that get acute migraines, once a year or, whatnot on a whim. But people with chronic migraines that are getting them multiple times a week, multiple times a month, those are cases that we see and often do find a neck ligament component to it. So migraine is, if anyone's ever had one, they are very debilitating. Like a lot of people cannot function. I've had migraines. You can't work, you can't function when you get them. They're pretty bad, and they really negatively affect people's quality of life, especially if they are getting them very chronically.
When you get them, what symptoms do you get?
I actually don't get them anymore because I've had prolotherapy to my neck, but I would get extreme nausea, vomiting. Like I wouldn't be able to drive. I very, very light sensitive, would have to wear sunglasses all the time. But really you just want to lay in bed. Like functioning is not really an option.
When did yours go away? Like what year was that? Because we've worked together. When's your 10-year?
This month, actually. So we've been working together for 10 years.
We've worked together. You actually, this was your first job out of your training, so you worked together for 10 years.
So it's probably 2013, maybe, that I got prolotherapy to my neck. And I, knock on wood, really haven't had migraines since. 9 years,
yeah. Like a lot of people don't realize migraines can be cured. Let me just tell you the story about Marion. You probably have heard this before. Like Marion would say her migraine headache started the day that we got married, but no, that's what she would say.
I think I've heard her say that, actually.
We know that can't possibly be true.
Of course not.
But anyway, so I remember, we get married, and then, she's got migraine headaches. And the thing about migraine headaches is they seem to occur whenever you have plans. So it's awful.
That's true.
So I remember, again, our plans are going to be all ruined again. And we're at we started out at a 1-bedroom condo, so that was our first place that we had together. And this was probably in, the early 90s. And I remember her first prolotherapy was actually on our couch in our...
That does not surprise me.
In our condominium. And she would get migraines all the time. And I'd be hard pressed to know when the last time she got a migraine.
That's
it's probably
awesome.
like you, it might have been 10 years. So
yeah.
So in other words, if prolotherapy can cure migraines, and of course there is people who have menstrual migraines and they have food allergy migraines. I mean, there's other causes of migraines, but a lot of people don't realize that if you have a structural cause of your migraine, theoretically you can actually, I know I'm not supposed to use the word cure, but let's just say you could be in remission for 9 years for her, or 9 or 10 years for Marion. So the studies show that about 1% of the world population have it. About 1 out of 5 people sometime in their lifetime will have a migraine headache.
So this just kind of shows there might be triggers. Everyone could have their own, unique trigger for a migraine, like heightened perception. If sounds are like really loud, really irritating, you might get visual changes. Sometimes that's called like an aura. Some people get numbness. In more severe cases, people might even notice that their speech is affected. But then when you get your headache, this was true in my case, like a lot of nausea, vomiting. Some people get sensory disturbances. They can't concentrate. It can be very disabling. And then afterwards, if your headache goes away, you don't necessarily snap right out of it. You don't just all of a sudden, oh, my headache's gone, I feel great. It almost might feel like a hungover kind of feeling, like you're just kind of really groggy. You still don't feel great, but your headache is, no longer severe, very tired. And then, in a lot of cases, until your next trigger, then it starts all over again.
Say if you got an email or a text, like say one of the nurses staff said, hey, so this person has a history of migraines, should we take them on as a client? Like, how would you decide whether somebody has a cervical cause of their migraine versus some other trigger or something?
Like you had alluded to before, there's different causes of migraine. Some are structural, some are what we might call systemic or non-structural, like a menstrual related migraine. So if all I know is that someone has migraines, questions I would want to ask are they cyclical? Like, do they, if in a female, do they happen at certain times of the month? Are they associated with things like neck pain, or does the person have neck pain? Do they have muscle tightness? Do they get clicking, popping, cracking in their neck?
Yeah.
Are they somebody that historically has needed to see a chiropractor to get out of a migraine? That might kind of tell me there's a instability or malrotation factor. These are kind of baseline screening questions that I would want to know before determining, yes, we should look into this further, or it doesn't really quite seem like a prolotherapy case.
Yeah. Because, often it doesn't even have to be about migraine, because we get so many emails from all over the globe, for different things, countries I never even heard of, we get emails from. And the staff will ask me, does prolotherapy help this condition? It could even be a condition I don't even know about, because there's people who have genetic, chromosomal abnormalities and all these things. And my answer almost always goes back to, do they have other signs and symptoms of cervical instability? Like we all know, cervical instability can affect the vagus nerve. So do they have sensitive stomach? Do they have nausea? Do they get tachycardia? Do they have dizziness? Do they have vertigo? Do they have tinnitus? The common things we see, because obviously if somebody just has migraines on the third day of their menstrual cycle, they, in that situation, you've got to get rid of the inflammation. So you take fish oils, you maybe get on progesterone, those kind of things. So are there other signs and symptoms of cervical instability? And I think somebody close to you, one of your relatives, I believe they lose vision, because sometimes you can get amaurosis fugax, or you get one eye where either before the migraine or during the migraine, and the ophthalmic artery, like when the ophthalmic artery closes, then that's a branch of the carotid artery. When that closes, you get that amaurosis fugax. Yeah,
that family member was actually diagnosed with what they called ocular migraines. Okay. That was what their diagnosis was. But basically where they'll get kind of dizzy and lose vision in one eye. Almost always related to activity. So not like normal activity, going to the grocery store, but like a really hard workout, run kind of thing, usually is what triggers that.
Yeah, and that might also be a sign that there's a neck problem.
Absolutely, it doesn't usually happen just from laying down. It's, like a really strenuous exercise where you might put your neck under a lot of strain.
Yeah. So that would be another sign. And then we had talked about, migraines. If you research the literature, almost all the literature will say that absolutely the trigeminal nerve is part of what causes a migraine headache. And we're going to talk about that. And a lot of people believe that basically the hypothalamus is responsible for like the aura part of it, and the trigeminal nerve is actually part of the migraine. And on these videos, we've talked a lot about how when you have cervical destructure or breakdown of the neck curve, that can block the jugular veins, which of course could give you intracranial hypertension, which of course can affect any part of the brain, including the hypothalamus. And then obviously if somebody did something like they were working really hard at the computer, or they did a workout or something, then that put more strain on the neck. Then vertebrae can rotate, nerves can get irritated, the jugular vein can get worse compression, and that can activate the trigeminal nerve, and then eventually you get a migraine. Years ago, we had a trainer, and she was showing us how to do transcranial Doppler. And when she was showing us, the person was actually in an active migraine. So I just want to kind of show they were in an active migraine. So what you see here is unbelievable dilation of the circle of Willis. This is basically the circle of Willis, which is basically right here. So the circulation of the brain primarily relates to what's called the circle of Willis. And the circle of Willis is made up of the branches of the vertebral artery, which are in the cervical vertebrae, and the carotid artery, which run along the anterior portion. And you could see here that these arteries are dilated, and it's mostly one-sided, and the person was getting a one-sided migraine, and you could see it's like pulsating. It's just pulsating. It's so much of, so basically during a migraine we can actually see the migraine in action. I couldn't believe it. It was so amazing. That we can see what blood vessels it is. Just was remarkable. So I just kind of just wanted to show that. When you have activation of the trigeminal nerve is one of the cranial nerves. It's cranial nerve 5. Now most people know the trigeminal nerve from trigeminal neuralgia, where you get really severe facial pain. And the trigeminal nerve does all the sensation, like the skin sensation. It does the muscles of mastication, so you know, it does that. It also innervates the tongue. So our patients who have like burning tongue and this and that, like the sensation of the tongue, not taste, but the actual sensation of the tongue. And the trigeminal nerve originates from the pons, but the neurons that make up the trigeminal nerve, the neurons, they go all the way down to C2 or C3. So that means any nerve input that's really severe at C1, at C2 can affect the trigeminal nerve, and they even call this area the trigeminal cervical nucleus. And what I find fascinating is when you look at all the injection techniques, the various injection techniques that can get rid of a migraine, they almost all involve the upper cervical. So when somebody's in acute migraine, and I've done this, I've done anesthetics in the upper cervical region and stopped the migraines. So there obviously is an upper cervical component, and anybody who's gone to like an upper cervical chiropractic, they usually will say that it does help cause the migraine to not be as severe, or it helps resolve it, but often they still get migraines because they have upper cervical instability.
A lot of times, too, in patients that I've seen with migraines, sometimes the TMJ is involved as well. So right here, like pretty much right by that trigeminal ganglion is your TMJ, your temporal mandibular joint. There is a big correlation, too, between your TMJ and your upper cervical spine. That is something, too, that we just want to consider in migraine patients.
Yeah, that's a good thought. Upper cervical instability or cervical destructure, where you get a breakdown of the cervical curve, that can cause irritation of the nerves around the upper cervical region. Then also the cervical destructure, the breakdown of the cervical curve, can block the jugular vein, which of course can, and also it can cause a block of CSF. And then when there's CSF stasis, the extra fluid can then accumulate around various nerves. The main nerve that we see it is the optic nerve sheath, cranial nerve 2, but it can also accumulate around the trigeminal nerve. So there's many mechanisms by which upper cervical problems or a breakdown of the cervical curve can lead to a migraine. And to be honest with you, I mean, we've never tabulated it, but I would say the results are spectacular. Like if you got a migraine case, like, wouldn't you feel confident?
Yeah,
like you could, I mean, really confident, like really, really confident that if they do have cervical instability, and how would we figure out whether they had a cervical problem that might be related to the migraine? Like, what tests do we do?
So aside from like history questions, which we talked about, for screening, we would do a digital motion x-ray where you're moving, where you're actually looking down and looking up, and we'd be able to see if there was any excess motion, especially at that C1, C2, and if there was, we'd be able to grade it. You know, is it mild, moderate, severe? And that would actually help us to determine if surrounding nerves there are getting pinched based on how and which way those bones move.
Yep, and this just kind of explains that when there's extravertebral motion here, it's going to irritate the trigeminal nerve, and eventually you get, oh, we didn't even talk about this, that the actual bad part of the migraine is from cerebral vasodilation.
Yeah.
So you saw that in the where the arteries got very dilated, and you could even see how it's pulsatile, how that might be really, really painful. And when people take ergotamines or sumatriptan or the triptans, they're
migraine medications.
They're vasoconstrictors, as is caffeine a vasoconstrictor. Anything that induces vasoconstriction then normally causes the migraine to go away. And then this just shows that if you have irritation of the C3 nerve, C2 nerve, C1 nerve, that can also irritate the trigeminal nerve. How many treatments would it take, or how do you determine how many treatments of prolotherapy?
That would depend on a lot, actually, on what their digital motion x-ray looks like. If it's mild, moderate, or severe instability, severe cases would need more prolotherapy. What we've talked about before, if their neck curve is straight or like an S, the far away from lordosis that it is, if we do have them do curve correction in addition to prolotherapy, I would say on average the 5 to 6 treatment range, but that could be less or more depending on what their DMX shows.
Yeah. At the beginning of this video, I said the number one cause of headaches, especially in the era where we look at cell phones and forward head posture, is ligamentous cervical instability. So we're assuming that somebody wants to cure their migraines. You have got to, get your computer system up like we talked about in other videos and stop looking down at your cell phone. Now, part four is where we're going to talk about how intracranial hypertension, in my experience, probably is the number one cause of headaches nowadays in the cell phone era, but also that is, in my opinion, from ligamentous cervical instability. Then in part 5, we're going to actually show prolotherapy treatments and how we would treat the various headaches with prolotherapy. Well, thank you so much, and thank you everybody for watching.